9:09. Let's head into the KUAM News Zoom room where we have the Chief Medical Officer for the Guam Memorial Hospital, Dr. Annie Berdalio. I hope that's your title. If not, you just got promoted. Good morning, Doc. Thanks for joining us. How goes it at the Guam Memorial Hospital?
Well, it's still going. We still get our, daily 1 or 2 COVID patients coming through the emergency room, but our census is still quite manageable. I think we have 8 COVID patients in the hospital and 3 what we call PUIs, or persons under investigation, which are basically may have some exposure, and we're just waiting for the test results. We still have 2 people in the ICU on the COVID side, and they're still on ventilators. So, but again, we just need everybody to pretty much stay vigilant and stay careful. I know that even for us, we all have vaccines or got vaccinated, and it's also been a long process. We're a year out, and we're all tired of being super careful. But I think it's still pretty critical, especially, as we open more of the community, and we're seeing maybe a few more travelers come back. So I think that's it always makes us a little worried for the future. But at some point, I think we will adapt and learn to live with, hopefully a small amount of this disease.
Doc, so you said that you guys receive 1 to 2 COVID positives through the emergency room daily and other PUI cases. Where are those numbers reported through the JIC?
Yes, they're reported as positive tests through the JIC.
Okay.
Some of them are OP positive, and they just come to the emergency room for care, but don't necessarily have to be admitted.
Right. I wanted to ask just briefly, if I could, about something that came out of the public health oversight hearing the other night. Dr. Cabrera had talked about the need to remain vigilant, because in the event that we see anything like a variant outbreak or anything like the second surge, that we wouldn't be able to make the ask for the travel nurses or the DOD doctors or any other supplemental medical personnel, because they're assigned and stretched thin in other areas. Is that accurate?
Yes, that is accurate. I think the federal government responds. A lot of these teams are emergency activated teams. So wherever there's the biggest surge in need, that's typically where they go to. And because the U.S. has been surging after our September to November surge, then they really their numbers went off the charts. So all of those assets have been relocated, or I should say reallocated to the mainland. So it's very difficult to, even actually during our surge, there was a lot of negotiating and basically begging on our part to get them here on site. And we were very lucky to be able to get that emergency team, where I believe it was 30 ICU nurses and 2 intensivists that were stationed here for 30 days. And I think we got them to extend it for another 15 days. But again, there was a lot of competition and pulling, and I think we also have tried to, again, we're hiring, we work with the contracting agency in the States to bring nurses here. And again, there's a lot of competition for those nurses. Actually, the going rate now is over $200 an hour for ICU nurses. So we're trying to keep the ones we have, even though we don't have a high census, because once we get the census, they're not going to be, they're not easy to move around that quickly too. So we're trying to keep at least a reasonable number of staff to respond in case, because there's not a lot of resources out there that can be mobilized that quickly anymore.
Is there any information that you could provide, any additional information regarding this 18-year-old that passed away? In the Joint Information Center report, it stated that she'd passed away from COVID. But when you look at some of the media stories that are being put out, the family's saying that she was tested at GMH and it was negative.
Well, Sabrina, I mean, obviously, because of privacy concerns, we can't really talk about any patients that have come through the hospital in any specific terms. I think, generally speaking, the testing that we do, there's several tests that we do. I think really everybody who comes through the emergency room gets a rapid test. So those are tests that we do immediately if actually all of our patients who come through the emergency room, we generally are testing them. So those tests come back very quickly in a 15 to 30 minute time frame. And we kind of base where we place them, what kind of isolation precautions we use initially on those tests, but they're not 100% accurate. So we also, again, I just mentioned our census, we have 3 PUIs, or people under investigation. Sometimes patients have symptoms that might be consistent with COVID, even though the initial testing is negative. And again, it's back to how we've been doing this now for a year and how exhausted everybody is of just hearing about COVID. I will tell you, 6 months ago or 9 months ago, if you sneezed, we didn't care what your test was. We would retest you 4 times if we thought there was a significant risk that you had COVID. I think, now we may be relying on these tests. The difference is the gold standard test, which is the PCR test that gets swabbed and goes to public health and gets tested at their lab, is a 3 to 4 hour test. So it takes several hours. It can even take a day or 2 depending on what their load is. But generally for the hospital patients, we get the results, twice a day, after the morning run and after the evening run. So those tests really are the confirmation tests. And I will tell you, for lots of patients, even when those tests were negative, if we were highly worried, they remained PUIs and remained isolated, and we repeated the test. For patients that the suspicion maybe was a little bit less, we went ahead and put them on the regular floors, basically the non-COVID areas. And this has worked pretty well, but again, it's not 100%. So, we have had cases over the year that patients go home and they get sick later, and we find out they were COVID positive despite having a negative rapid test. And there's been very rare positive tests. I know that we've had 1 or 2 where the rapid test came out positive, but the PCR came out negative. So again, it's not an exact science, and the timing is, I think, sometimes where the information doesn't get shared appropriately.
So did an 18-year-old pass away from COVID on Sunday? Was it clinically diagnosed COVID, or was it through rapid
Well, we had an
testing?
8-year-old who had a positive COVID PCR.
I'm sorry, could you say that again?
So the PCR test was reported positive by the public health lab on an 18-year-old.
But was the initial test taken negative, or?
Yes, the rapid test was negative.
And as a result of the family going to the media, because I think even on our Facebook, one of the comments was it was false information, false news. Have you spoken to the family since?
Yes, we spoke to the family, so they, again, we're not really allowed to share, despite the family wanting to share in the media. Again, you can always contact them, but we're really not at liberty to share any of that patient information. It's just, it's a privacy law, and so, you're pushing me into a very fine line that I think, again, you want to ask general questions about our testing, you can. What we say or don't say to the family is protected, so I would appreciate maybe we don't ask questions in a public setting like this.
Okay.
Doc, you mentioned the gold standard and the rapid test accuracy. What concerns do you have with the accuracy of those rapid tests? Because that's what we're using now to conduct, I believe, a lot of the testing.
Well, Chris, I think in medicine, we have lots of different tests. A lot of them have different accuracies, and we choose what test to use based on what we're trying to accomplish. So, I'm an OBGYN, so a pap smear, or all of my patients undergo diabetic testing when they come as pregnant patients. So we have several different tests we use. When we're testing we want to test every single person in the world. We want a test that will pick up as much of the disease as we can, but it's easy, it's cheap, it, works fast. So those are how we decide. There's a million tests out there. And for COVID, I think, on the market already are quite a few tests. Some tests you go home, the pregnancy test, you just pee on a stick, versus me getting a blood sample from you and measuring how much pregnancy hormone you're taking. So the validity of all those tests are a little bit different from each other, and which ones we choose to use depends on how many people we're testing, so if they're symptomatic or not. Clearly, the tests we use in the hospital, we try to use the most accurate tests that we can, because these people generally are sick, they're symptomatic. We also have an issue about containment within our facility, protection of our healthcare workers. So I think, but we also need speed, because we can't have people backed up in the emergency room and outside in the parking lot waiting for a test that takes 3 or 4 hours. We also don't have enough space to isolate every single person indefinitely. So the rapid tests are actually quite accurate. They're just no test, even the PCR, is 100% accurate. When we're screening a large population, like for cervical cancer, we want every woman to get a pap smear. That test is not a test for cancer. It's a screen to tell me that you don't have cancer. So if we do the test on large amounts of people and it comes back negative, the negative test really is what we're looking for. We don't care about the positive test. The positive test doesn't tell me you have cancer. It just means you need more testing. Then you go to the real test. So when you're screening lots of people, we want that test to be sensitive, that if we're not if it says it's negative, we're not missing a lot of disease. But we sacrifice how specific the test is. So there's lots of patients who get a positive pap smear. They come for further testing, but they don't have cancer. But it's very few relative to the number of people we're testing. So in mass testing situations where we're going to test 500 people, that test is a little bit different. And we sacrifice some of the accuracy because, again, is it easy? Do we have a lot of them? You know, does it require one drop of blood? Does it require, you know, sophisticated lab testing? And that's been a big issue in the beginning of the pandemic, is if it takes 3 or 4 hours to run a lab test, it's going to be hard to do 1,000 tests in a day. I think in the beginning we were limited to, I think the machine holds 30 or 40 tests, and we could only do it twice a day. And actually we were doing it 3 times a day. We were just running the lab 24/7. We had the lab person, you know, we lent them a lab person so that they could run more continuously. But as these other tests became available, again, we sacrifice certain things so that we can do many more. So I hope that answers your question, but it applies in all of the things we do in medicine. There's multiple tests with different degrees of sensitivity and how specific the test is as well.
We had a oversight chair for GMH, Speaker Teresa Lahi on earlier, and we were talking about the budget, and specifically for the Guam Memorial Hospital. It looks like GMH is facing an $8 million budget cut. Is that correct? And can any of you speak on how that will impact the hospital?
Well, I'll leave that for
I'm not aware of I'm not aware of that particular number. I'd have to confer a little with our chief financial officer, who has been preparing our with all of our input, has been preparing our FY22 budget.
Mm-hmm.
So I would have to confer with her on that number. But you know, COVID has not been, has been kind to us in some ways as far as bringing in federal funds. There have been some silver linings with COVID for us. But now that we have less COVID in the hospital, and we, of course, we're hoping for no additional surges. We're hoping to get back to some sort of normalcy, whatever that is, so that we can start, generating the kind of revenue that we can generate to be able to support. We're always striving to find ways to support ourselves, because we know, because of COVID, the whole of the government right now is really financially challenged, and so we have to achieve or strive for some sort of independence financially, and so we're looking for ways to do that. We're looking for ways to we're looking to the future to enhance our outpatient services because of the better reimbursement rates that we could garner there. But I'm not sure of that particular number that you threw out. I'd have to confer with our CFO.
Mm-hmm. Is there anything new with the SNU or SNF?
The residents are still at the Catholic Social Services. We have a census of 10 as of this morning. Again, we are in the process of heading towards a final design for the isolation of our B wing at our skilled nursing facility. So we are planning to bring them home but we're still going to have to go through a construction phase for that project. So we're still taking care of them over there, and they're still doing their part as far as this response to COVID by keeping them this vulnerable population safe over there.
We do get a lot of questions about visitation. Is there any changes to the visitation policy over at GMH?
No, we haven't changed our visiting policy. I think we're, again, much like planning for surging. We're trying to wait till the end of February because of the schools opening. So I think once we feel like the numbers really aren't going up, we know it's important for our families to be able to be with their loved ones. So what we do try to do, and again, some people don't realize, is keep in communication via telephone or FaceTime or Zoom. A lot of the units have a lot of extra iPads that were donated or devices so that their family members can keep in close contact if they wish.
Can you give us, I guess, a rundown of GMH board? I understand. I believe they're scheduled to meet tonight. Is that right?
We
met yesterday.
We met with our BOT HR subcommittee last night, and tonight we are scheduled to meet with the board. But this is specific to a COVID update. Yeah, we so twice a month we meet with the full board. One is always a COVID update regarding our response, and the other one is a full board meeting. So tonight's is just a COVID update for the board.
Where are we on the laundry list of repairs and stuff that was kind of a big conversation before the pandemic hit? You know, the elevator, the roof, the electronic health records thing. Have we been able to resolve those issues?
Is this the Army Corps of Engineers report?
Yeah.
Well, relative to the Army Corps of Engineers assessment, at least 50%, I would say more than that, are underway. We're progressing on those in one form or another. Some of them require a design phase, others do not. And so, of course, those that do not require a design phase, we're able to move along a little quicker. Like relative to the roof upgrade, which not only includes the roof, but window and doors, improving all of those potential areas where water could potentially seep into the facility during a downpour or a tropical cyclone. That one is going to be going through a design phase where we're letting out the RFP soon for that, and we're going to be designing that upgrade in a way that we do it in a phased manner. So as they're designing it, as they complete a phase in the design, we'll be able to let out that portion. We'll be doing it in small chunks so that we can mobilize it and complete it quicker, especially in those areas of the hospital that are worse than others as far as the roof.
Right.
The EHR is another one. We never stopped heading towards implementation, full launching of the EHR. Our initial launch date was in May of this year. COVID has definitely had an impact on that. And so we will be delayed in our implementation. We've informed the board that will be pushed back somewhere around to help build the infrastructure, the IT EHR, and the training that they require doctors, nurses, allied health professionals. They had to focus. They could not focus on the implementation. They had to break away. Many of them had to break away because of their clinical responsibilities in the COVID response, and that's what caused a significant delay in implementing the EHR. But we are still working with MedSphere to do this, and actually we're planning for them finally. The other thing is they were never able to come out here. It's all been via Zoom, the trainings and different implementation aspects, and so that makes it a bigger challenge. But they are going to be able to finally come out here after, of course they would be probably in an initial quarantine, but we're finally going to be able to get them out here. We need them out here in order to effectively implement this EHR. Um, the elevators, I mean, we did upgrade elevators 1 and 2. These elevators, of course, these were never brand new elevators that we just upgraded the existing ones, and so, they just require constant maintenance and attention in order to keep all 4 elevators up, and so we're doing that. Relative to the main electrical distribution panel and sub panels, we continue to have a strong relationship with GPA because we've decided at this point, because we're going to be building a new hospital, that it wouldn't be prudent for us to replace the panel at a cost of anywhere from $6 million or higher. So we're maintaining the existing, which means replacing those parts that we need to replace to make sure that this system stays alive. And so, we're picking and choosing which projects we absolutely need to sustain ourselves for the next 5 to 7 years, and in the most cost beneficial way. And so like I said, quite a few of those projects are underway. We're not shying away from them. Some of them, of course, require availability of funds. We designed, for example, the OR to upgrade the ventilation system and even the flooring of the OR. The design phase is done, but it requires quite a bit of funding. Some of that funding was federal, quite a bit of it for the construction phase, but the federal funds that normally would come to us for that project, like DOI funds, they, even during COVID, their focus shifted. So we've been pending DOI funds for that particular project for about a year, for about the length of time that COVID has preoccupied us. So those are some of the examples. We are near completion on the communication center relocation project. We're about 2 weeks away. So some of the subcontractors are working with our main contractor to finish that project, and they are the last group of people that are going to be leaving the Zwing for now, and then we'll be addressing the Zwing as well. This is the
Z-Wing. That sounds like zombies.
No, the Z-Wing, that's on that's up to the right when you're facing the hospital, right? Are you frozen?
Say that again.
The Z-Wing, that's to the right when you're facing the hospital. I thought that was
yes,
shut
ma'am.
down.
Sure.
Mm-hmm.
It's about 50 years old. That's where the existing communication center we still reside. So that we cannot,
right. So
we couldn't.
that's where I went to kindergarten. Well, more than 50 years ago, I went to kindergarten in the Z-Wing. Right at the very end was my classroom.
What about non-COVID census? Non-COVID and then more capacity?
The non-COVID census currently is at 109. Seven of those are ICU patients, non-COVID, with 3 of them on ventilators. And so, yeah, the non-COVID census has been staying kind of steady around 110, fluctuating below and above that. And so it's very manageable, like Dr. Budaya was saying earlier.
How does that compare to pre-COVID, pre-pandemic admission levels?
Yeah, it's right around, our average census is about 120 to 130. So it's still a little bit below. Also, again, but there are certain units like the ICU. Pre-COVID, we really only we only had enough staff to have 6 to 8 ICU beds. Now we have enough staff for about 12, and our aim is to keep it around 14, which is our total ICU bed availability. So 14 to 18. During COVID, we had several units open. We had the 14 ICU beds. We had a Care 2, which has 4 beds, and we opened the recovery room and the operating room as a non-COVID ICU. So we really flexed to, close to 25 ICU beds, but the staffing for that relied a lot on travelers. So again, we're trying to come to the sweet spot, which is sometimes a difficult number to get to just because of the availability of staff.
How many staff are fully vaccinated now at GMH?
We've vaccinated those that have received one or both doses, 66%. This is both the staff and the licensed independent practitioners. And those that have completed, that have received both doses, 61%. Basically 864 out of a little over 1,400.
Wow.
Because we're counting the doctors in that count.
Mm.
All right. Anything else over at GMH?
I think that's about it. I mean, we really, this was a longer one for today.
Well, we thank you guys, for
Definitely.
making time
Yeah.
to come on and providing us an update on what's happening over at the hospital.
Really appreciate it. Just consider it a dry run for your board meeting tonight.
Yes, thank you.
Thank you, Doc.
Stay safe.
Okay.
Thanks for
I'll
everything
see
you
you
guys
guys.
are doing.
We'll take a break here on the link. We'll be back with more next. Good morning.